I'd like to introduce some evidence and clinical cases to show you when the root membrane technique is necessary. This paper is a systematic review of alveolar bone resorption after tooth extraction. The paper reports that the amount of horizontal resorption in the alveolar bone after tooth extraction was 3.87 millimeters. This systematic review reported the same thing. It reported that the horizontal resorption in the alveolar bone 6 months after tooth extraction was 3.79 millimeters. Based on these papers, if root membrane can be performed, it should be done aggressively to reduce bone resorption. On the other hand, Professor Buza reported that bone resorption is less likely to occur when there is more than 1 millimeter of alveolar bone on the labial side. My mentor, Dr. Hayashi, divided the labial alveolar bone into 2 areas as shown in this figure. Then Dr. Hayashi classified 4 patterns of post-extraction bone resorption according to the thickness of the alveolar bone. As shown in the figure, bone resorption after tooth extraction is minimal in the 2 cases on the left. On the other hand, the 2 cases on the right are expected to have significant bone resorption after extraction. Based on these facts, I hypothesized that the root membrane technique is necessary only when the alveolar bone, the labial side is less than 1 millimeter, and tested it in actual clinical practice. The first case is a 62-year-old male. His chief complaint was that his front teeth were broken. The patient required implant treatment. 12 teeth had more than 1 millimeter of alveolar bone on the labial side. So I planned immediate placement. I got such a good primary stability with the normal drilling protocol. This is the ISQ scale of Ostel company. According to this data, at the ISQ 70 or higher, immediate loading is possible. In this case, immediate loading was performed because the conditions were met. X-ray showed that the implant was placed in the correct position. As the progress of the implant site was good, I measured the ISQ again 8 weeks after surgery. The ISQ was stable, so I took an impression. The implant superstructure was placed 12 weeks post-operatively. It can be seen that there is no marginal bone loss and progress is good. This is a picture taken 4 years post-operatively. 12 teeth show that there is no alveolar bone resorption on the labial side. The second case is a 24-year-old female. Her chief complaint is the aesthetic improvement of her left upper front teeth. These teeth had short roots and were considered to have a poor long-term prognosis. So I decided to perform an implant treatment. As a result of diagnosis, implant placement was planned for 21 and 23 teeth, 23rd teeth. These teeth have more than 1 millimeter of alveolar bone on the labial side. So I plan to immediate placement. First, I carefully extracted the teeth so as not to damage the gingiva. Next, I prepared the implant site. The bone quality was poor, so I improved the bone quality using the osseodensification technique. The result was good primary stability. 23 was also treated using the same protocol, resulting in good primary stability. Temporary abutment were then placed and immediate loading was performed. The X-ray showed that the implants were placed in the correct position. As the progress of the implant site was good, I measured the ISQ again 8 weeks after the operation. The ISQ was stable, so I took an impression using prime scan. The implant superstructure was placed 14 weeks post-operatively. It can be seen that there is no marginal bone loss and progress is good. 1 year after surgery, there is no gingival recession and the aesthetic appearance is maintained. These are 1 year follow-up X-ray. No marginal bone loss or labial alveolar bone resorption was observed. The third case is a 33-year-old female. Her child's head had hit her 11 teeth, causing a root fracture. The CT showed that the alveolar bone on the labial side was less than 1 millimeter. So I planned to perform the root membrane technique. First, I examined whether the alveolar bone on the labial side was healthy by bone sounding. Root membrane was formed because the root was healthy. The implant was then placed without touching the root membrane, and I filled the gap with beta TCP. Temporary abutment was then placed and immediate loading were performed. 8 weeks after the operation, ISQ was stable, so I took an impression with prime scan. The implant superstructure was placed 12 weeks post-operatively. There was no alveolar bone resorption on the labial side, and good results were obtained. No marginal bone loss or labial alveolar bone resorption was observed on X-ray at 1 year. The last case is a 34-year-old female. A large bone defect was found at the 22nd teeth root apex. Many dentists recommended a bridge after extraction, but the patient refused to have 23rd teeth prepared. Therefore, although it is a very difficult situation, I planned implant treatment. The CT showed that the alveolar bone on the labial side was less than 1 millimeter. So I planned to perform root membrane technique. First, I examined whether the alveolar bone on the labial side was healthy by bone sounding. A similar flap was designed to remove a large apical region. A complete curettage was then performed with the diamond bar. Then the root is split and removed palatal portion. The root membrane was formed. I drilled the bone with tensile bars and got good primary stability, despite the low bone mass. The ISQ was 67, so I chose one stage. I filled the bone defect with beta TCP. The treatment was completed by bonding the temporary crown to the adjacent teeth. Progression of the implant site was good. I measured the ISQ again 12 weeks after operation. The ISQ was stable, so I made a provisional restoration. And I took an impression after 14 weeks with prime scan. The implant superstructure was placed 17 weeks post-operative. There is no alveolar bone resorption on the labial side, and good result obtained. No marginal bone loss, labial alveolar bone resorption, or gingival recession was observed at 1 year. Conclusion. Before extraction, the bundle bone thickness is measured with CT to determine whether root membrane should be performed. As a result, minimally invasive and long-term aesthetic results can be achieved. Thank you for your attention.